It's really inspiring to see the number of people who are interested in getting together and talking about something like training in the context of the autism field. And as Stelios said, I mean, the one thing that I can agree with is that I have no special expertise around training, and that there's expertise around sort of the technical aspects of training. But I think we're sort of moving into a kind of a new world in terms of what we want our learners and professionals to accomplish. There are very different kinds of tasks than training is often thought about. It's always unfortunate when you sort of arrive at the point of your presentation sort of after you've sort of kind of finished preparing it. But it strikes me that one of the challenges that we face from a training perspective is that our training paradigms are really built around helping people develop technical skills. I mean, we have a very specific problem. We work with individuals to develop particular technical skills to sort of fix that problem. But the challenges that we face and the opportunities that we face in the autism field are much more complex in nature and what people would describe as more adaptive issues. You're moving into a complex system where there are complex dynamics and multiple perspectives, and to accomplish system change in that kind of environment, it really is much more about about transformation, and the kinds of skills that are required to accomplish that are actually very different than the kinds of technical skills that we typically receive through our educational training. So, the challenge, not only for this talk, but I think for the discussion today, is how do we empower our learners, our colleagues, and ourselves really to tackle those important challenges around sort of achieving improvements in care, better collaboration, better quality of life, better inclusion. These are not simple technical problems that one addresses through a quick fix or a simple technical skill. So with that, I'll kind of move on to the content of the presentation, which I've titled Perspectives on Training, Application to Autism Care and Research. And really, I come to this much more with more expertise as a learner and trainee, I think, than sort of a trainer. And although Stelios has sort of very kindly suggested that I'll have a lot of empirical evidence to draw on today, I think this is very much a reflection to set off, I think, what promises to be a very exciting agenda today. And I think in the spirit of many of the points in this talk, I think the whole day is set up to be inclusive and collaborative, with dialogue and reflection. And I think it's by working collectively that we can tackle these important issues. So I have no conflicts to disclose other than, as Stelios was saying, I really do miss all of you here in Ontario. It's really nice being back. And I'll just kind of give some greetings from the Zwaigenbaums in Ontario. So one way not to get invited back to a talk is like to start off by showing all your family pictures. But, sort of going way back with so many of you in the room, this is a picture from my surprise birthday party last year. I actually just turned 50 a week ago, and my wife figured that having a party for my 49th would be the best surprise. And completely pulled it off. So I sort of wanted to start with my own developmental trajectory, kind of the training lows and training highs. So it's kind of sad when you want to include a picture from your past, and you don't actually need a sepia lens because it's just sort of naturally yellowed from age. So this is me with my first year anatomy group at U of T Medical School. It's interesting that the guy in the top left-hand corner, if I can figure this out, anyway, Mike Dickinson on the top left-hand corner is actually the current president of the Canadian Pediatric Society. So, certainly there was one person from our group sort of went on to accomplish great things. So, I have to, it's kind of sad, but, thinking back to those sort of formative years, there's probably a lot more training lows that sort of came to mind than training highs. And I remember my first anatomy exam, and I think for many of the people in health training here, this is kind of old school stuff that I had gone through. I graduated in 1991. It was a bell ringer exam where we were evaluated on our knowledge of anatomy, and I tried to learn all the veins and tendons, and then there would be sort of a specimen that was draped over with a sheet, and you would have like sort of 2 minutes to sort of answer a list of questions about what you're seeing. And I got to the first station, and I honestly couldn't tell whether it was an arm or a thigh, and it was all kind of downhill from there. And just that horrible feeling, sort of lack of confidence and lack of mastery was just awful. And then fast forward to my years of pediatric residency, which was at another Ontario institution, and completing what I thought was actually a pretty successful and positive rotation as a senior resident, and then getting my evaluation from my preceptor, who had some positive things to say, but he sort of summed up by saying, and Dr. Zwaigenbaum has no future in academic pediatrics. And I kind of questioned him about it. He said, oh, I guess I didn't mean to say no. So he ended up taking out that word, but I never quite understood what his motivation was. And you know, sort of typical evaluation of the time, it sort of arrived a month later. It was in writing. There was sort of no discussion or reflection or kind of co-development of it. So I certainly sort of entered my research training with the bar set pretty low on training experiences. But you know, in terms of training highs, I mean, I have very fond memories here at McMaster. I completed my clinical fellowship in developmental pediatrics in Toronto with Wendy Roberts, who's actually a wonderful teacher and mentor and trainer. And I certainly have learned a lot about how to approach training sort of in working with Wendy and her team there. I did a research fellowship with Peter Zentmari and the team at the Offord Center. I had a chance to spend time with Dan Offord. I remember walking in a room and go, hey! And he just was this incredibly exuberant, brilliant person who I think really set the tone around education and training in child mental health and developmental disabilities, along with Peter Rosenbaum in Kenchild, which was also a big part of my formative years as a trainee at McMaster. And you know, the things that we're going to be talking about today around partnerships and teamwork and collaboration was very much the spirit and the culture at the Offord Center and Kenchild as a trainee. Since that time, and sort of taking on a faculty position and becoming part of the autism research community, I've had the opportunity to be part of this wonderful National Autism Research Training Program that was established through support through CIHR and a terrific group of senior investigators, initially led by Eric von Bahn. And then when Eric moved to Oregon about 5 or 6 years ago, I became the program director, which, you know, interesting challenge, sort of again, sort of as someone with not really a lot of special expertise in training, to think about how one carries on this great tradition. And again, not really a traditional training approach. I mean, it's really about training the research leaders of this generation. You know, again, and looking around the room, many people who are graduates of that program, and who are, you know, tackling these complex clinical and research issues through a very different paradigm. It's less linear. It's less about sort of addressing technical issues, and again, it's more about addressing system change. And certainly I've had very positive experiences in my kind of particular area of research around early diagnosis of autism, and in particular interactions with parents and self-advocates and the broader autism community. So the broad objectives for, you know, maybe less so this talk and more thinking about the sort of what we've got in store for us today, are to be thinking about the principles that support successful training across a range of contexts. And I think specifically how we shift our emphasis from addressing technical problems to addressing adaptive problems. How do we actually create a system of care that is welcoming? How do we create a society, really, that's welcoming for people with autism and their families? And then ultimately reflect on how these principles can be applied to enhance autism care and research. So, you know, just to be specific, you know, in terms of what do we mean by training, you know, kind of go to dictionary definition. You know, ultimately, it's the process of learning the skills that you need for a particular job or activity. So, you know, we're going to be, I think, blending this with many other concepts today. I mean, there's broader education, how we sort of achieve our sort of professional skills and identities. I mean, there's coaching and membership where we encourage and support and bring out the best in people in terms of their roles. There's partnerships, which are well represented around the room today. All these are an integral part of training, but they're not a substitute for training. I mean, they're all important building blocks, but there is an element of training that is about sort of the development of particular skills. There's another side of training, which is sort of kind of more training for a swim meet or weight training meet, which isn't quite exactly what we're talking about today, although I may sort of back to that at the end. So as I suggested, historically, and kind of until very recently, when we think about training, it's in very traditional kinds of contexts. It's the development of technical skills, the development of a sort of a disciplinary set of competencies, and the sort of kind of basic sort of research skills. And I have to say, even though I say traditional, even McMaster wasn't so traditional when I was here 20 years ago. And 10 years ago, but as a research training 20 years ago. So technical skills, like as a physician, like to start an intravenous, or as a therapist to kind of learn the specifics around a particular intervention. Disciplinary training. So there are many disciplines represented in this room, and all of us have gone through a training process where we've developed those basic competencies. And research, traditionally is about sort of a very specific goal, achieving a degree, achieving a specific set of competencies. And the goals of these traditional forms of training really are fairly technical. I mean, you learn to do an IV, and it's pretty clear whether you're successfully done it or not. You're either in the vein or you're not. You have a certain success rate. You have a certain proportion of kids who are willing to talk to you after the experience. So there are very specific criteria for success. There are ways of assessing fidelity of implementation, whether it's a medical procedure or an intervention. And then on the research side, there are important competencies like asking good questions, developing technical skills, being competitive for funding, as unfortunately the case. And then the outcomes ultimately are pretty directly tied to this set of competencies that you're developing. So, was the procedure successful? Was the intervention administered to a certain degree of fidelity and standards of care? And did you do what you set out to do in your research? Did you defend your thesis? Did you get a job? Did you sort of kind of function effectively, but albeit even if it's within your own silo? But there are a lot of other important roles, as I suggested, that are more of an adaptive nature. And this slide had a few iterations, because initially I was thinking about it, who are the leaders that I respect, and who are the people that are clearly successful products of their training experiences. But these roles here, that leader, interdisciplinary professional, innovator, they don't necessarily sort of kind of people that are sort of kind of at the extreme, sort of at the high end of the org chart. I mean, these are roles that we really all strive to take on and all can accomplish. And when we work within our teams, I mean, these are skills that we would all like to bring to the table as we contribute to tackling the important problems of the day. So, we can all serve in leadership roles in partnership with our colleagues within service teams in healthcare, in education, in the advocacy world. In terms of working effectively as an interdisciplinary professional, I think sort of looking around the room, I think almost all of us strive to do that. In a way that doesn't quite look like what we learned in sort of our kind of undergraduate or even professional education, but in terms of our real world training and experience, being able to become more flexible in terms of our own identity, in terms of the ability to collaborate and work respectfully within a team, it does require a certain skill set. And likewise, to think outside of the box and address a complex problem and actually affect an important change requires innovation. But how do we train up these kinds of skills? Because the skills, the goals that we're trying to accomplish are pretty lofty. I mean, we're really trying to accomplish transformational change and improve a system. So I can easily work with a group of learners and teach them how to administer the ADOS. It's a lot harder to teach a group of learners to improve diagnostic care. So how do clinicians improve the whole diagnostic experience for families? How do we approach diagnosis in an efficient way in the community to make sure that children and adults are receiving kind of expert assessment, that they're being appropriately assessed, and yet we're dealing with the tensions of the number of individuals that need to be seen, the fact that there's such diversity among individuals with autism, so it's not always a one-size-fits all. I mean, we can sort of reflect on how individually we might tackle those problems, but the foundation of it is equally important. How do we actually train professionals to sort of tackle these problems? How do we help ourselves and our colleagues and our learners develop these kinds of skills? So I think the key points here in terms of these adaptive issues are that technical skills and content expertise are essential, but they're essential starting points, and so that they're needed but not quite sufficient to really address system change. That none of us can tackle these kinds of things in isolation. So all of these roles involve collaboration, teamwork, and partnerships, and in that way, we need to be thinking about that skill set sort of, as being integral to our training approaches. And again, the problems to be tackled really are quite multifaceted. So this is a slide and a concept that was really taken from the notion of effective collaboration. But I think one might argue that the success of any training effort as well depends on the content and the goals and the results. I mean, there's no question that we need learners to have a certain set of skills and competencies. But we also need to teach learners to actually understand the process of addressing complex problems, and also recognize the importance of relationships, not only in terms of being collegial, but in terms of being effective in tackling these complex problems. And looking at the people in a room, Stelios was talking to you about my earlier time management skills. I'm honestly going to look at Stelios for a 10-minute warning when I'm getting close, because this is, again, this topic was a bit intimidating to take on, and yet it's actually really been quite wonderful reflecting on where do we need to go in terms of our training efforts. And we're kind of operating a bit without a safety net, because we do have an empirical base for technical training, but not so much for this kind of adaptive training. So best I can do perhaps is to reflect. So this is the old Patterson building. It wasn't quite as flashy as the Ron Joyce, but I certainly have a lot of happy memories running across the street from the Evo building to the Patterson to hang out with my friends and colleagues over at the Offord Center. And certainly my formative experience was as a research fellow and a master's student in the HRM, or Health-Related Methodology program here. Back 20 years ago, it was already very much a multidisciplinary environment, and I think about the experiences just as a research trainee that have been really formative in terms of how I operate not just as a researcher, but even as a clinician. So one of the first kind of memories as a research fellow I have here was sitting in on Dr. Zutmari's genetics project. And Lorraine would be running around pulling together the files for this. And there were 4 of us, including Bill Mahoney, that would sit down and kind of ponder over these clinical files of individuals that Peter had seen and the research team had seen. And we would just sit down and kind of have it out about, does this individual have Asperger's condition? Does this individual have an autism Do they not have a spectrum disorder? And it was designed around the technical objective of coming up with a best estimate diagnosis. But those conversations around sort of how we think about diagnosis, the meaningfulness of subtypes, the lack of meaning around subtypes, and the importance of gender and development in informing sort of diagnostic classification has certainly stuck with me as I kind of continue to work as a clinician. So again, that collaboration and discussion and challenging and arguments, have been incredibly formative as a training experience. I also had the good fortune to both work in a clinical setting as well as in a genetics lab, and that opportunity to sort of bridge across research worlds, again, was very formative in terms of thinking about how to work as part of teams. Certainly the culture at the Autism Center, which I think remains, is that we do operate as part of a team, and everyone's role is valued. And looking back, and again looking now, if anything, there's sort of a reverse hierarchy, right? It's kind of the investigator that's sort of at the bottom of the totem pole, and really relies on other members of the team who know how things operate and know your strengths and your failings, and really together sort of support the success of the research effort, and as importantly the networking and the relationships with colleagues and with families. And I think the concept of a team being so integral to research success, I think continues to inspire efforts here, and I think you've really taken it up a new notch with MacART. Certainly I was encouraged as a learner to be very self-directed. Peter would frequently kind of move me outside of my comfort zone in terms of being in front of a group and presenting about something that I knew very little about. So that's one thing I have experience with. And certainly the mentorship and encouragement in the sense that the door was always open. And again, that there wasn't this sort of kind of false hierarchy based on sort of simply experience or educational degrees. There was certainly an element of technical skill development, and I think that as we think about the unique skills needed to tackle adaptive problems, it's important not to forget that certain competencies and technical skills are still the foundation of operating effectively. So, there are certain technical skills that I had a chance to develop in terms of assessment and research skills, working in the lab. And I thought it would be worth, as part of this talk, to sort of reflect on sort of what is the evidence base around just sort of instruction. So, I'm a bit embarrassed to present this because I know there are people from the educational system in this room. I'm going to talk briefly about the Marzano 9 from James Marzano. So James Marzano is an educator who in the late 90s did essentially a systematic review and meta-analysis of the educational literature and came up with 9 kind of critical instructional techniques that are essential in creating an effective learning environment, helping students acquire knowledge, and helping them apply that knowledge. And again, there are people in this room who will be able to speak in greater depth about these principles than I could. But I just wanted to highlight these because in reading about them, they actually resonated with me in terms of they may be effective for kids learning to read and to learn basic math skills, but they do apply sort of across a greater range of educational and training experience. And I certainly found that I was reflecting sort of based on some of these principles in terms of kind of what was helpful for me in terms of developing technical skills. So so the 9 strategies. So and thinking about how they apply to more adult learning situations. So identifying similarities and differences, but in understanding concepts. But more importantly, sort of thinking deeply. Trying to move to sort of deeper concepts. And in particular, the way Marzano talks about this, to really make it meaningful, and in that way, co-constructing with the learner. And moving from these principles, and again, these were the things that sort of really resonated with me. So that when one is developing technical skills, it's important to follow the manual and do it to fidelity, but it has to be meaningful. I think it's much more engaging. And one sort of, it sinks in when you understand sort of the deeper meaning, sort of that drive the specific technique, and co-constructing with that meaning with the learner is really essential. The whole notion that developing competencies can be a partnership between the trainer and the learner, and that the learner shouldn't always accept at face value sort of what they're being taught, but rather be encouraged to think critically about the material and to ask questions. That asking questions is not challenging, but rather is respecting and really kind of being invested in the learning. And then as part of that, encouraging self-reflection and problem solving, and again, the McMaster spirit of self-directed learning. So back to Marzano, homework and practice, non-linguistic representation, so moving beyond just verbal descriptions and more thinking about hands-on training opportunities, kind of thinking about concepts visually, and then learning cooperatively. And again, it's very much the very much the culture here at the master. So lots of hands-on opportunities, thinking about it in different ways. So for someone who can't tell the difference between an arm and a leg, find ways that are kind of suited to the learning style of the trainee, and then cooperative learning. I mean, I'll talk a little bit about our Autism Research Training Program, but I think the most powerful experience in working in that is just seeing the community that's developed among the learners and sort of how much learners teach one another and themselves. And I think as teachers and instructors, we're even in developing basic competencies, if we can set up a situation where we're kind of going along for the ride and the learners are really doing the heavy lifting, I think that's where we've been successful as trainers. And then finally, the specifics, and again, sort of very consistent with how we think about learning here, setting objectives, providing meaningful feedback that's based on sort of the specific skills that you're trying to teach and criterion for competency, encouraging learners to generate and test hypotheses to promote deeper learning, and to use sort of kind of creative learning strategies to help people acquire and retain skills. And again, for me, what it sort of boiled down to is very much active involvement of the learner in goal setting and giving feedback. And Marzano really advocated for learners to take an active role in not only receiving feedback, but learning approaches to providing constructive feedback, which probably as a trainee and then as a colleague, sort of working in an environment where we're addressing complex issues, being able to give feedback to colleagues, to sort of to bring back to what our objectives are, to be able to give honest feedback about the direction that things are going, I think is really important. With the understanding that feedback isn't actually evaluating. It's not necessarily sort of providing sort of personal criticism or even necessarily praise, but it's about sizing up sort of what the task is and sort of helping everyone be on board and working collectively, and ultimately to achieve a deeper understanding. So another formative experience for me has been working as part of the Autism Research Training Program. This is something that the autism academic and general community in Canada is actually very proud of. This is really something that's quite unique internationally. Tried to imitate it, but never accomplished it. I mean, there's been individual workshops, and there's certainly sort of training funding programs, but this notion of a community of practice in research training that where learners and faculty come together not only to master the basic content, but to really think about how we're going to tackle the important problems, I think has actually been very successful in fostering the next generation of research leaders ready to tackle these kinds of adaptive issues. And I don't have to look beyond this room to see some of our very accomplished graduates from this program. It's been a very well-rounded training experience where people have the opportunity to have mentors outside of their disciplinary area, to think about research more broadly in terms of societal issues, ethics, family engagement, knowledge translation. So again, sort of starting with a more narrowly defined training program in a trainee's own institution and sort of working as a community to more fully develop that experience. And the model was really quite flexible. There was an opportunity for people going through graduate training or doctoral training to be part of the Autism Research Training Program for a large extended period, sort of during 3 out of the years of their training. There was also a track for professionals to come in and do additional research training after they completed their clinical training as occupational therapists, psychologists, pediatricians, psychiatrists. It was a rigorous peer review application process, so which I think, as you know, when you're completing an application, even though it's a lot of pressure, it really forces you to reflect on who you are as a learner, what you want to accomplish, what the goals that you have as a professional. We came together and hung out a lot, sort of in an intensive summer school, or kind of initially thought of as autism boot camp, but that was just really the beginning. For the first years, it was very content-based, but for the more senior trainees, it was actually much more about getting together, sharing ideas, talking about the research work in progress, sitting down and having tough conversations with faculty about some of the challenges facing. You know, how do we develop better diagnostic care? How do we address the needs of adults with ASD? You know, how do we, again, sort of address the issues that we're going to need to address in the real world? And one of the highlights, I think, of the Autism Research Training Program was support for trainees, not only to attend our premier research conference, International Meeting for Autism Research, but actually to be able to invite kind of a senior researcher, kind of internationally, you know, kind of people in the field, and have them talk about not just their research work, but actually their career experience, and kind of reflect back on their own trajectory as a learner, and kind of moving through different eras in the autism research world. And you know, we heard from Lorna Wing and Connie Cassidy, who presented last year, Helen Taker-Flesberg, Sally Rogers. I mean, people are really senior in the field who, you know, were fortunate to get to hear about their specific research, but they actually would talk about their experience both as a learner and as a mentor. And that, again, that was incredibly helpful for all of us. So, you know, I think by traditional metrics, it was a successful program. You know, again, you in this room, we have a good handful of the graduating trainees, incredibly productive, have genuinely moved on to be leaders in their fields. And as I said, that there were a lot of lessons learned that I think can apply outside of research training to sort of the kinds of training programs that we want to have. So again, first and foremost, that sense of community among trainees and culture of interdisciplinarity. That people came from the genetics lab, they came from pediatrics, they came from health policy, and it became a bit of a microcosm of how we would love to see research operate in the real world, where people aren't only operating within their own discipline, but they're actually getting together, you know, sharing their skills and sort of tackling issues collectively and collaboratively. There were opportunities for leadership, so the learners were very much involved in the direction and the governance of the program, and it's a very inclusive program. And you know, and we were, you know, I think one of the strengths of the program is that over time, you know, because of the academic accomplishments within the community, there are actually a number of adults with autism who came from their academic institutions and became an integral part of the research training program. We were also fortunate to be able to involve community leaders, including parents, in the summer school. But as many of the people in the room know, it is a bit of a crossroads for the Autism Research Training Program. And you know, the biggest challenge, I think, as in any kind of research enterprise, is funding. So the Autism Research Training Program originally was launched because there was an opportunity through the Canadian Institutes of Health Research to form these interdisciplinary research training programs. And it was a strategic initiative, which CIHR has moved away from. So it's not that CIHR isn't invested in training, but they've sort of shifted from strategic initiatives to more sort of researcher-initiated initiatives. And art has sort of gotten kind of lost in the wash. So, you know, it's kind of bittersweet. You know, we just had a wonderful summer school in London. We're fortunate to have funding from a couple of private organizations that will allow us to run one more year of art, and we'll open it up to a new group of trainees and hold one more summer school. But you know, we have a year. You know, our task is sort of set out for us in terms of developing a sustainability plan. But there were some tough lessons that I think are relevant sort of more broadly for training initiatives. And the reality is that the training initiatives usually have a clear endpoint. You identify a specific issue that's needed. You want to build capacity in the community around a particular intervention. You may have longer-term training, but that's more sort of around professional disciplinary training. So, you know, when it comes to research, like how do we actually build and sustain capacity needed for effective interdisciplinary care and research? But, you know, in retrospect, and of course, you always have the 2020 vision in retrospect. It was, you know, our funding relationship with CIHR was a very traditional funding relationship. They were the funder. They put out a call for applications. We wrote a grant. they gave us the money, and we kind of went off for 10 years and kind of did our thing. But that's not really how funding relationships operate in a sustainable way. And Stelios' comments at the beginning about how MacART is thriving, it's very much through relationships, and the funders are an integral part of the MacART community. So it really seems that within a training initiative as work, as well, the way to be more effective, and I hope it's not too late for art, but it's really that the partnerships need to be embedded into the training initiatives so that the funders become an integral part of providing strategic direction, governance, this sort of sense of engagement and ultimately shared ownership and responsibility. And as we think about sort of training priorities today, the reality is finding the resources to sustain these opportunities is so essential, and thus we need to actually think about a very different kind of relationship with funders in the context of training. Okay, and then briefly, how am I doing for time still? Not too bad? Okay. So I want to just talk briefly about a new training challenge, and again, more as an opportunity for reflection and collaboration with you, because this is certainly not unique to what I'm taking on personally or what we're doing in Edmonton, but something that's occurring across the country, including a number of centers in Ontario, and that is around building community capacity for autism diagnosis. So kind of shifting gears a little bit to this specific area, the chronically and historically, one of the biggest challenges that really colors the experience for families and sort of has a big impact on sort of the long-term experience and trajectory for individuals with ASD is just sort of basic access. So access to assessment, access to intervention. And it's very much a fluid and continuous process, because even as we make efforts to improve access, of course the numbers continue to grow. And as we increase knowledge and awareness of how to identify autism in the community, we simply sort of generate more business, and there's sort of a greater need for assessment. So no question, as rates increase, so the wait lists for assessment. It's only recent that we're coming to this idea, but the truth is, in pediatrics, for most chronic conditions, there's an explicit partnership between community consultants and the specialists that work in the children's hospital. So if you have a headache or you have a heart murmur, and even if you're referred into the specialty clinic, many of these clinics actually have a process by which they review the referrals and have specific partners in the community that they would actually decant some of those referrals, because the reality is the nature of the assessment need is quite suited to a community assessment versus a specialty assessment. That's a relatively new concept in developmental disabilities. I mean, we're kind of used to that idea, say, for ADHD, where many children with attention deficit hyperactivity disorder are diagnosed in the community. But we've, sort of embraced this concept of sort of highly specialized assessment for autism. And I think, well justified in the sense that there's been an emphasis on quality, multidisciplinary teams, kind of holistic understanding of the child to come up with sort of the best possible foundation for understanding for the family and also for intervention. But I think we're starting to recognize that there are trade-offs in terms of the investment in time and resources into the length and sort of complexity of the assessment versus sort of the ability to provide that service. And knowing the diversity and heterogeneity among individuals with ASD, there is room for creativity and flexibility here, and to build capacity sort of among our community professionals who, I think in retrospect, have been chomping at the bit. I mean, not all of them, certainly autism assessment work isn't as straightforward as seeing a child with a runny nose or an ear infection. But the reality is that we have wonderful partners and colleagues in the community. We have a rich tradition of consultant pediatrics within Canada that are ready to rise to the challenge and really contribute. It's not a huge empiric base, but there are impressive demonstration projects internationally that suggest that community teams and even individual community professionals can be trained to the point where their assessment of diagnosis is in good agreement with a comprehensive, highly resource-intensive, multidisciplinary team. There are a number of challenges and opportunities related to taking this on. It's pretty clear that partnerships are going to be essential to changing, not only to building skills in the community, but to sort of change the culture around diagnosis. I have to say, in Edmonton, you know, at our own rehab hospital, we've kind of driven that culture. I mean, we've really promoted the concept that we should be the only game in town, and it has kind of cut off the other community professionals. So we now need to socialize this concept that one can have a quality diagnosis in the community. So working directly with policy decision makers is going to be very important, because there are some pragmatic issues around eligibility for treatment services where there needs to be buy-in for a new diagnostic model. Certainly working with community pediatricians and other healthcare and service providers is going to be essential, both in terms of developing the specific competencies and also sort of in changing worldviews about, so that community professionals do feel empowered and confident in making diagnosis. And then, of course, there's the critical partnership with parents. For parents to feel that they're receiving quality assessment, for parents to feel that they have input. So again, this isn't a purely technical issue, so understanding sort of parents and also the experience of individuals with ASD as they've previously gone through the diagnostic process, and understanding sort of what makes it a positive experience, sort of what information is essential in the moment, what sort of ancillary aspects like the intake process, the feedback process, the navigation process post-diagnosis. I mean, how do we embed this within sort of a new diagnostic approach? And then recognizing that as we partner with these groups, it's really sort of has broader implications. I mean, the truth is, if we partner with community pediatricians around diagnosis, there's an opportunity to partner more broadly around healthcare. So, you know, what's the continuity of care for individuals with ASD? And why are we just talking about pediatricians? Because we've kind of set up adults with ASD to have no primary care providers, because, you know, traditionally we've sort of had this very paternalistic approach that all individuals with ASD need to have a pediatrician because they're going to be more knowledgeable, they're going to be more familiar with child health issues, and there are no healthcare providers to transition people to as they reach the age of 18. So how do we reach out to family physicians and involve them in the assessment and particularly in the follow-up process? So, you know, chatting with colleagues here yesterday, chatting with colleagues in other centers across the country, I think many centers are now embarking on this process. And again, we're sort of flying without a safety net. This is kind of a relatively new approach, and yet has tremendous potential to expand capacity and also break down walls between specialists and community professionals. There are specific techniques that can be used to support this. There is a telehealth-based platform for training professionals called Extension for Community Health Outcomes, or Project ECHO. It was actually developed in the States around improving care around people with chronic hepatitis, but is now starting to be applied in mental health, including in Ontario, and now sort of within autism. Autism Speaks supports the Autism Treatment Network, and one of their priorities currently is building capacity for pediatric care and primary health care in the community for patients with autism. And as opposed to telehealth, that's patient-specific. So it's not so much that a family is in the clinic seeing a clinician at a distance, but rather it's targeted at practices. So so the person facilitating the discussion would be on, kind of on telehealth, kind of video conference with a number of community practices where health professionals would sit around the table. There would be a brief presentation, kind of providing little content, opportunity for discussion, case presentations, that real kind of collaborative learning. The focus to date has been more on the follow-up and management of healthcare, kind of chronic physical health issues associated with autism. But the group in Toronto are starting to apply this to building a capacity around assessment, and there really does seem to be great potential there. And thinking about how community diagnosis will kind of shift our kind of trajectory of assessment. And in building capacity, we want to build capacity across the lifespan. We want to build capacity for adult diagnosis, and we want to push the boundaries around early diagnosis. But as we push the boundaries around early diagnosis, we'll probably increasingly find ourselves in a situation where we're seeing infants and toddlers who have early behavioral differences, but where there may not be certainty around sort of the ultimate diagnostic outcome. and it forces us to consider, you know, how we think about intervention, and ultimately that intervention is around enhancing function, sort of identifying specific challenges, identifying sort of functional skills that we want to develop, and being able to provide that support and intervention. And parents have lived with that kind of uncertainty around recognizing that there's a need without a categorical diagnosis, and I think it's becoming increasingly clear that as a group of professionals, we also need to become a bit more comfortable with that uncertainty, to be able to act and implement intervention even when there isn't necessarily sort of a categorical diagnosis. And there's no question that Ontario has been very much a leader in this area. And the pilot toddler intervention programs through the Ministry of Children and Youth Services have really been kind of a dramatic advance in terms of demonstrating at a community level the impact that working with toddlers with early signs of autism, but not necessarily a categorical diagnosis, can have in terms of enhancing function, improving child and family well-being. And I'm delighted that I'm part of a team that was part of the thinking around the development of the social ABCs, the development of the manualized program, of which was led by Susan Bryson and Jessica Bryan in Toronto. And I'm absolutely delighted that somehow the social ABCs sort of landed at McMaster Children's Hospital, the implementation being led by Carolyn Roncaden. And this is such it's almost like this sort of family event where we've got kind of colleagues that sort of know each other outside of this program, but had an opportunity to implement this evidence-based, wonderful program. It's such a wonderful example of effective training, sort of kind of moving outside of the academic setting into the community, empowering a broader range of therapists with the skills to support toddlers and their families, and then providing the opportunity to think about the broader system of care. How do we push the envelope around the whole concept of intervention? So just some final thoughts. So the number of examples of training in complex areas, diagnosis, intervention, research training. Training is an essential component to system advancement, but rarely is it limited to teaching technical skills. And as we think about sort of the pressing issues for the autism field around building capacity around assessment and more effective treatments and inclusive workplaces and inclusive society, I mean, clearly this is going to require a skill set that goes beyond starting an IV or even effectively implementing a particular intervention with fidelity. And we have our work cut out for us, but we're but again, looking out at all of you here, your commitment to training and your commitment to the autism community, I feel very optimistic that we're going to be able to tackle these issues and at the same time build training capacity to help cultivate the leaders and the trainees who are going to take on these problems sort of as we start to fade away. Effective instructional techniques are essential, but they're not sufficient. And we actually need to think about leadership training and thinking in an interdisciplinary way and being effective partners and collaborators. We need to embed those competencies in the training program so that as we develop our disciplinary competencies, we also have these kind of real-world leadership competencies as well. And then, I feel like I'm a good example. I'm up here talking more as a student than as a supervisor or trainer. I mean, training, like learning, is very much a lifelong process and is all about continuing to tackle the important challenges, moving outside of our comfort zone and thinking about what we can do. So just briefly, back to the comment about a different kind of training and the notion of moving outside of one's comfort zone. I just want to put in a brief plug. So as the same time doing research training, clinical training, I've taken on this crazy challenge of training for my first marathon, which just happens to be in Hamilton in a month and a half, supporting delighted to support Autism Speaks. When you run these races, they take photos of you running, and I had about 100 pictures. This was like the only one where I wasn't like hunched over and my face kind of clenched, but it's very small, so you can't see it very clearly. But I did want to put in a plug, and certainly for a good cause as well. So anyway, again, I'm delighted to be here and really looking forward to the discussion today. So thank you. So I think we have time for a couple questions or comments, and I think, and keeping in mind that I think that a lot of these ideas are going to be what we're going to be having a chance to talk about later today.
Okay. We've got a mic for questions. Anyone?
If there's one at the back, then it's again, I'll be great.
Cameron has a. Hi, Lonnie.
Oh, hi.
First of all, thank you so much for talking about community pediatrician capacity, and if anyone wants to talk about that later, I'll be more than happy to get into that with you. But my question is actually around diversity and representation among our trainees, and moving that diversity into being the trainers. So autism is obviously a complex challenge to solve. I think we need a broad set of backgrounds and experiences to be able to tackle it, and I love that we're seeing more self-advocates involved in training, and I think we need to really make sure we're getting to the level of being trainers as well. But are there other areas where we need to make sure that we're representing? So our Indigenous communities in Canada, do we have sufficient representation from the LGBTQ community? So how are we going to make sure we're bringing everyone into the fold and giving them the opportunity to get to that point of being the trainers?
Yeah, it's a great question, Lonnie. Thank you. You know, it occurs to me as you ask that if I think of the Autism Research Training Program, for example, I think we do a good job of promoting inclusivity and diversity once people are in the program. But I'm not sure that we've done such a great job of creating the opportunities to apply, to even be in kind of graduate training programs, for example, that would allow an individual that kind of provide sort of the basic prerequisites to be an applicant to these kinds of programs. So I think we need to be proactive in thinking about sort of the very start, kind of cultivating opportunities among those communities that you're describing. And kind of going out to the service providers, to the schools. I mean, those communities are better represented in the broader community and in the volunteer community. And I think really sort of taking the opportunity to think about how do we help support individuals sort of along that trajectory so that they can, as you're saying, sort of get to that kind of greater stage of sort of leadership and involvement. And likewise, you know, again, we do fairly well at the training stage. I'm not so sure sort of that we're quite there at the faculty stage either. And again, I think we need to be more proactive about promoting that successful transition. And I'm not, you know, I have a colleague actually at U of A who is a graduate of art, was diagnosed as an adult with Asperger's syndrome, and you know, it's not been an easy road for her, but she's been quite successful on faculty. But you know, it's still a pretty rare occurrence. And again, I think that as we promote inclusivity and ensuring that the autism community is actually well represented among the leadership and the decision makers, I do think you're right that we need to think about how to help with that capacity building and that important transition.
Do I need a microphone, or can I just talk?
It's dead.
Oh, it's dead.
Maybe it's running.
Okay. Thanks. Hi. So first of all, Lonnie, thanks very much for a very thoughtful talk. I mean, you touched on so many things that I think probably, you know, all of us in the audience have had a chance to talk about in our training and life and, you know, professional activities. The thing that really struck me was your comments about how over the years, autism being an example, but there are other examples of places where there are very highly trained multidisciplinary teams in very specific settings, specifically children's hospitals, that are the keeper of the diagnosis or the keeper of the treatment. And this idea of shifting this to think about there are interested and able people who are not in this specific site who can help with, you know, the wait lists and doing proper assessments and getting people into treatment more quickly, or things like that. And that's a huge shift from moving to you have to come here to there's more capacity. I wonder if you can make any more comments about kind of how that has gone for you in Alberta.
It's very early days. I mean, I have to say that I think we're not as far along as many centers are in Ontario. I mean, there's certainly some community sites in Ontario where that's very much an operational partnership. And I think with the recent new investment, I think a number of the children's treatment centers now in Ontario have been very active in reaching out. I think there's resistance, but it tends to be resistance from our own colleagues, kind of. I think we have this very narrow lens because we feel good about the quality of assessment that we do, sort of in our kind of ivory tower, but it's easy to become disconnected with the reality in the community of how long people are waiting. And in terms of the initial feedback, I think we kind of went into it sort of worried that parents would feel like they're not getting the same quality of assessment. But the initial feedback is the parents have been delighted that they're not having to wait as long. They're actually having a very positive experience sort of working with their pediatrician or the school-based team. Again, speaking to colleagues in Ontario, I'm looking at Ronit right now, and head of the Autism Clinical Program. I think that initial feedback has been pretty universal, that families are actually quite game to participate in this transformation because they recognize the positive impact that increasing capacity could have. And again, there are a number of community pediatricians that are quite keen to take this on, and have actually felt quite sort of constrained in terms of recognizing when kids have autism and yet not being able to sort of help families sort of move on to the next step. So, so I have to say I have little experience. It's been positive so far. But I think this is going to be very much an example where we need to kind of keep in touch and sort of share successes and sort of how we're grappling through the challenges. But I think it's very encouraging. Yeah.
So sensible.
Yeah.
Just make a comment to that. I think what we should not forget is that people that are in the community pediatricians and family doctors have a big advantage about our ivory tower position because they know the family and they follow the child over time and they can make the decision after many, many visits. And I think that is not to be put away. Right. That's a great advantage they have, and I think we need just to empower them and strengthen that in that judgment.
Yeah, I think that's a very good point in terms of that kind of that foundation and continuity of the relationship. And I also want to be clear that it's not so much kind of swinging the pendulum from multidisciplinary to necessarily solo assessment. I think it's sort of more the concept of a virtual team and a community-based partnership. And one model, in fact, that has been successful in Alberta, in Calgary, has been sort of a community-based diagnostic team that is actually led by speech and language and OT and early childhood education, where they will see kids in their own environments, like in the preschool, in the home, and then sort of bring that information back to the child's community pediatrician to sort of further kind of formulate the diagnosis and provide that feedback together. So it doesn't have to be a community pediatrician or family doctor working in isolation, but rather sort of kind of leveraging kind of community capacity and expertise from other disciplines and sort of pulling together what I think can be a high quality diagnosis. Good. Great.
Thank you.
Thank you.